My name is Dr. Richard Sterling. I'm a professor of medicine within gastroenterology, hepatology, and nutrition at Virginia Commonwealth University, where I also serve as the chief of hepatology, and I'm the chief clinical officer for the Stravitz-Sanyal Institute for Liver Disease and Metabolic Health. As an undergraduate, I was a chemistry major, and I particularly liked biochemistry. That then led me to get a master's degree in biochemistry, and I think that's really when I fell in love with the liver, understanding that all of those metabolic pathways occur in the liver. In medical school, I had a very influential person in my life who was Willis Madre, who was my chairman of medicine. He was also a very well-known hepatologist. And he also had a big influence in me and my desire to become a hepatologist. During my internship and residency, we saw a fair number of patients with both acute and chronic liver disease. And what I realized that while most of my colleagues either ran away from those patients or didn't want to try to deal with the problem, I was drawn to those patients and I wanted to try to understand what was going on with them and how could I really help them. Most of the liver disease that we were focusing on was chronic hepatitis C. And when I completed my fellowship and came back to VCU in 1997, we now had some treatments for hepatitis C. They weren't great, but they were there. And it turns out that the HIV patients, the current HIV medications that they were using were approved and became widely used in the mid-1990s. And therefore, many patients were now living from their HIV and getting into problem with other conditions. And so the infectious disease group and the HIV providers here approached me and said, we're doing a great job now with our HIV management, but now a lot of our patients have liver disease, and would you help them manage it? So it turned out that both there was a need here at VCU, my interest and expertise in viral hepatitis at the time allowed me to fill that role and become an expert in HIV-related liver disease. Early on, we thought that the hepatitis C natural history was much, much more aggressive in those living with HIV than with those without. But we've learned that's probably not the case in the modern era. And that was actually the focus of my NIH K23 grant, where I looked at the natural history of hepatitis C in those with HIV and compared it to those without. And using paired biopsies, which is a biopsy at 2 points in time, we were able to show that the natural history of progression is really not that much different than people with HIV than those without HIV. And so now, for at least the last 10 or more years, we've had excellent treatments for hepatitis C, and HIV patients respond just as well as any other patient. Once we as a community were able to tackle hepatitis C in those living with HIV, my next area of focus was on hepatitis B in those living with HIV. And that was the focus of my R01 grant, which I led a multi-center cohort study trying to look at what happens with HIV patients who also have hepatitis B. I then now currently am more involved in fatty liver in people living with HIV, which is another major liver disease that we see in our general population. But it also turns out to be quite prevalent in those living with HIV. We've learned that when patients have chronic liver disease, whether it's viral hepatitis or fatty liver disease, they can still have other comorbidities. In particular, we know that patients with fatty liver disease are at very high risk for developing cardiovascular disease. And one of my current projects is looking at cardiovascular risks in HIV patients with and without fatty liver disease. To live, you have to have a liver. And so that's one of the things that gives me passion. I think the liver does so many things in the body, including making most of the proteins that the body uses. It detoxifies, it can regenerate when it's injured, we can replace the liver with liver transplantation. And now we have wonderful treatments for several liver conditions, such as hepatitis C. That makes it a wonderful organ that we can both study and help our patients through improvements in medicine that I have seen in my lifetime. When I was early on in my training and my career, I realized that perhaps the only thing worse than doing a liver biopsy was either having one done on yourself or teaching someone else how to do a liver biopsy. And that led to my interest in developing non-invasive assessment tools to assess disease severity in liver disease. So I was very fortunate in the early 2000s to be able to have access to a very large cohort of hepatitis C patients who also had HIV, who had undergone a liver biopsy. And through help through an industry partner and a statistician, we were able to develop the FIB-4 index, which is now one of the most widely used non-invasive tools to assess liver disease and is recommended by not only the ASLD, our main liver society, but also many other societies. When I developed the FIB-4, I didn't realize how well it would stand the test of time. And the FIB-4 was developed now almost 20 years ago and remains one of the most widely used and validated tests across all kinds of different liver diseases. It surprises me what misconceptions there are in liver disease. And even if you look at some of the current media and what's in movies and television shows, once someone mentions they might have a liver disease, it's sort of perceived that it might even be as bad as having cancer. And when someone says, oh, I have to go see my liver doctor, when in fact, we're nice people, and most people are going to live with their liver disease and not die from it. And then again, with a lot of advances that we've had, both in viral hepatitis, now with fatty liver disease, with approved medications, our expansion of liver transplant, and the management of liver cancer and other disorders, we can really provide many, many patients with help to improve their quality of life and to improve their longevity of life.